Let's start.
Right. Okay, we'll start. Hi,
We are live, please.
good evening, everyone. It's my pleasure to invite all of you to this wonderful webinar on, Deuce 3. I'll be introducing the speaker today. Unfortunately, Dr. Namrata couldn't join us now. Hopefully, she'll be joining us soon. Dr. Geeta Iyer doesn't need much of introduction, I believe. Okay, more than 2 decades in deep in ocular surface. Probably one of the first person in India to choose ocular surface as a niche area and kind of focus on that. Uh, at present, she is the medical director of Code Eye Care at Chennai. Also, she is one of the director or board member of TFOS and a part of the Deuce 3 team, especially the diagnostic report. So we are going to hear what is Deuce 3 and how is it different from Deuce 1 and 2 right from the horse's mouth. With that, I welcome Dr. Geeta Iyer. And before she goes on to her talk, we have a small, presentation from Microvision. Probably Mr. Navneet can take over now for the presentation.
Yes, sir. Yeah. Yes, sir. Thank you, sir. Yeah. Thank you, sir.
Thank you, Navneet. Now, Dr. Geeta, you can start your talk.
A very good evening to one and all of you, to all the audience, to the panelists, and to Dr. Vinay for your very kind introduction. Thank you. I thought I should start off with this collection of cases. So, this was a 28-year-old male who quit his job, symptomatic, with a very short tear breakup time, as you can see here. And you can also appreciate that he has what we would call as a partial blink. A 30-year-old male, symptomatic with severe ocular surface staining. This was a patient with post-viral conjunctivitis, dry eye. A 60-year-old female with rheumatoid arthritis, asymptomatic with severe staining of the ocular surface. And then there was another patient who was absolutely normal on slit lamp evaluation, a 28-year-old young boy, depressed, with no signs but significant symptoms. Based on DUCE2, this would have been the diagnosis for each of these patients, either evaporative dry eye disease, aqueous deficiency dry eye disease, ocular surface disease, or neuropathic pain. DUCE2 basically relied on categorization of patients into these boxes. And the question that was lingering in the minds of the experts was, can a framework help us interpret disease and guide decisions? For years, we have tried to answer what type of dry eye this is. DUCE3 asks a different question. Why does this patient have symptoms, and which are the drivers that matter the most? I'm happy to be presenting today in the forum of Ophthalmic Pathshala of the AIOS Scientific Committee, and I would like to thank the Chairman Scientific Committee, Dr. Namrata Sharma, for having given me this opportunity to speak on this particular topic. I'm one of the board of directors of the International TFOS, and we have seen the long journey of DUCE from DUCE 1 through DUCE 3 from 2007 to 2025 with 80 experts from 19 countries. DUCE 3 has been formatted and published last year. And this is what I will be speaking on, TFOS DUCE 3 from consensus to clinical interpretation. Dry eye is one of the few diseases where the patient can be miserable, the eye can look absolutely normal, and both can be right. TFOS DUCE 3 is an attempt to make sense of that. So let's jump straight into the diagnostic framework for dry eye disease that DUCE 3 provides. How do we diagnose DED in DUCE 3? There's a screening questionnaire which has a cutoff for positive symptoms. And along with that, if one of the signs are present, as is indicated here, either a tear film marker or the ocular surface staining, put together, both of these help us to diagnose dry eye disease. The screening questionnaire is a little different in DUCE 3. It is called the OSDI 6, the Ocular Surface Disease Index 6, which has been formatted to standardize symptom assessment, and TFOS DUCE 3 recommends the use of a single validated screening tool, which when you look at the questions, you can understand that it has been selected for its sensitivity, for its simplicity, and for its practicality in routine care. And this is a questionnaire that is applicable across geographical boundaries and across all patients of all age groups. The role of symptom questionnaire in DUCE 3 is one where it is adopted as the screening questionnaire, and symptoms are absolutely essential for diagnosis, with it being standardized, pragmatic, and a clinic-friendly approach. If there are no symptoms, there is no dry eye disease. Symptom assessment is standardized and is non-negotiable as far as DUCE 3 is concerned. This position was taken in order to avoid labeling large asymptomatic populations to have dry eye disease, to prevent risk factor-based overdiagnosis, and to maintain diagnostic specificity in general practice. But of course, with all these kind of boxes, you will have a trade-off, and sensitivity is lost at the severe chronic silent end of the disease. But this is a boundary choice that was specifically made by DUCE 3. The tear film stability testing, where non-invasive methods take priority in DUCE 3. The NIBUT is preferred. Clear cutoffs have been defined for the NIBUT being less than 10 seconds. And with the takeaway from the TFOD of the Asia Dry Eye Society classification, the fluorescein tear breakup time was shortened to less than 5 seconds as one of the criteria for the diagnosis. How you test basically matters, and non-invasive assessment is prioritized in DUCE 3. This is what defines diagnostic confidence for dry eye disease in DUCE-3. Diagnostic confidence means being reasonably sure that your patient's symptoms are coming from dry eye disease and not from something else. And towards this end, symptoms are mandatory. One objective sign is sufficient. Not all tests need to be positive, and it's a maximum of 2 tests here, unlike DUCE-2, which had a maximum of 3 tests. We all know that dry eye disease has and can present with symptom sign discordance, but when you have discordance, it lowers the confidence and it prompts reconsideration. Symptoms are mandatory. If the patient has no symptoms, we do not call it dry eye disease. They could have differential diagnosis of dry eye, they could have risk factors or preclinical changes, but not disease. So again, it is mandatory that symptoms are present to diagnose active dry eye disease, but their absence after treatment reflects control, not absence of disease. So this is very simply put what DUCE-3 tells us. Symptoms with a OSDI-6 score of greater than or equal to 4, presence of signs, and both of them present together. One of the signs that is mentioned over here, either a poor tear stability, hyperosmolarity, and or ocular surface staining, helps us diagnose dry eye. But there are various judgment layers that have been added clinically to what appears very simple at this point in time. And this is where comes in the viewpoint of differential diagnosis. Now we know that the differential diagnosis for dry eye can be exhaustive, as you can see on the list here. Dry eye is not always dry eye, and that is why it is important that we exclude differential diagnosis. You could have symptoms plus T-but reduction is this dry eye disease. You could have symptoms plus diffuse staining. You could have symptoms plus the allergic papillae leading to tear film instability, in which case it would be an allergic disease and not dry eye disease. The basic underlying factor in DUCE-3 is that the markers or the signs that have been earmarked for diagnosing dry eye disease should specifically arise from tear film instability or lack of homeostasis of the ocular surface. So you rule out a non-tear film or ocular surface loss of homeostasis cause to ensure that you're not dealing with a differential diagnosis. Why this matters clinically? Because this prevents overdiagnosis of dry eye. It prevents mistreatment of infections, toxicity, allergy, and neuropathic pain. And it reinforces dry eye as a disease of homeostasis, and it's not a catch-all label. Can dry eye disease and differential diagnosis coexist? Very much. If another condition fully explains the symptoms and signs, then it totally excludes dry eye. If it explains only part of the picture, then dry eye and the differential diagnosis can coexist. So here are a few examples of clinical situations like viral epithelial keratitis. Does it exclude dry eye disease? You have a patient who is symptomatic and who has a corneal staining, but this corneal staining is due to a primary epithelial disease and is not due to a tear film or surface homeostasis failure, and therefore, of course, it is not a dry eye disease. Similarly, for acute toxic epitheliopathy, the entire clinical picture, if explained by the toxicity, excludes dry eye disease, and so on and so forth with the different examples that have been cited here. How do you differentiate dry eye disease from the differential diagnosis? This is done based on certain aspects that have been highlighted here. The primary mechanism, the symptoms especially, which usually tends to be more of dryness, burning in true dry eye disease in comparison to pain, photophobia in the masqueraders. The nature of pain, it's usually chronic, the temporal pattern, it's usually chronic in dry eye disease versus acute or subacute in the differential diagnosis. And the response to lubricants could be partial or consistent relief and minimal or paradoxical. So there are certain ways, certain questions, and certain signs that help us differentiate the two. So this adds the next layer here. We have symptoms, we have signs, we have excluded the differential diagnosis, which is when we reach to a diagnosis of dry eye in the patient that we are dealing with. But of course, there are more judgment layers, and this is where we bring in risk factors for dry eye disease, which have been categorized here into non-modifiable or modifiable and consistent or probable risk factors. Where do risk factors sit in the DUCE-3 diagnostic methodology, especially with respect to case finding and screening? Where it helps us to identify patients who should be questioned or screened, it should raise clinical suspicion, but risk factors by themselves do not establish diagnosis. Contextual interpretation of risk factors, they help explain symptom severity, variability, or discordance, but they do not replace objective signs. TFOS DUCE-3 embeds risk factors upstream of diagnosis to guide case finding and to provide context. Risk factors versus association. Well, a risk factor increases the likelihood of developing dry eye disease, whereas an association is commonly seen with dry eye disease, but it does not really prove causation. Neither risk factors nor associations are diagnostic criteria for dry eye disease. They are just an additional layer in helping us make a judgment. Again, why this matters clinically? So that it prevents us from calling every digital user to have dry eye, labeling asymptomatic Sjogren's patients as diseased, and treating risk instead of disease. So the highlight of DUCE-3 is precision over presumption. And this brings me to how dry eye disease has been defined by DUCE-3. It is a multifactorial symptomatic disease that is characterized by a loss of homeostasis of the tear film and or the ocular surface, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities are etiological factors. So when you look at the difference in the definition between DUCE-2 and DUCE-3, DUCE-2 defined dry eye as a multifactorial disease of the ocular surface. DUCE-3 defines dry eye as a multifactorial symptomatic disease where homeostasis has been expanded to include the ocular surface in addition to the loss of tear film homeostasis in comparison to DUCE-2. Symptoms definitely were mandatory both for DUCE-2 as well as DUCE-3. DUCE-3 recenters dry eye around the patient's symptomatic experience and not just the tear film biology. Disease was what dry eye was already categorized as in DUCE-2, but it is probably essential to just take one look as to what is the difference between disease and syndrome. Disease, dry eye initially used to be termed as dry eye syndrome, but is now called as dry eye disease. So disease is a condition with a defined underlying pathophysiology and a predictable course where symptoms and signs arise from a common biological mechanism, vis-a-vis syndrome, which is a collection of symptoms and signs that tend to occur together without a single clearly defined underlying cause. So why dry eye is a disease and not a syndrome is something which has already clearly been outlined, because it has a defined core pathophysiology. Patients' symptoms are mechanistically linked to the biological processes such as tear instability, hyperosmolar stress, inflammation, and neurosensory dysfunction. It demonstrates a natural history, and clear diagnostic criteria and thresholds exist for disease definition and monitoring. It is a disease because its symptoms arise from an identifiable biological failure and not a coincidental symptom cluster. Inflammation was given a very significant role in DUCE-2, and it shifts from assumed primary driver to a contextual factor in DUCE-3. So DUCE-3 recognizes inflammation as context dependent. It may be primary or it may be secondary. And there are certain instances where inflammation is often muted and secondary to loss of homeostasis. And therefore, DUCE-3 clearly mentions that inflammation is not universal. Its role must be interpreted and it must not be assumed. So we look back at the graph that we have already seen. This is something that we know. When you have symptoms and when you have signs, when you have excluded the differential diagnosis, what you're dealing with is dry eye diagnosis. When you do not have symptoms and you have only signs, then what you're dealing with is ocular surface disease or neurotrophic conditions, or it could be a dry eye differential diagnosis, it could be a risk factor, or it could be preclinical changes. When you have only symptoms and you do not have signs, then it is neuropathic pain or a transient discomfort. And you put all of them together and you get the algorithmic flow when you see a patient who has symptoms and or signs that appears to be dry eye disease at the first glance. Narrowing down the diagnosis is what we have done so far, and this is a Venn diagram that illustrates that dry eye disease requires the presence of both signs and symptoms and exclusion of differential diagnosis. At the same time, we need to understand that dry eye disease can coexist with other forms of ocular surface disease and symptomatic conditions. One thing that we need to relate to is that DUCE-3 does not give a severity grading for dry eye due to the recognized weak association between signs and symptoms, and even between different clinical signs. It was not possible to generate an evidence-based weighting system to quantify the overall severity. And when you look at the management subsequently, you will realize that a step ladder approach is not applied based on the severity of dry eye. Rather, it depends on something else completely in DUCE-3. So once we have understood the logic of how the diagnosis of dry eye is made, the next question is, how do we proceed further from is this dry eye? So we've seen the definition tells us what dry eye disease is, that it is a loss of tear film and or ocular surface homeostasis with symptoms. We've seen what the risk factors and associations are, which tell us who is more likely to develop dry eye disease. They raise suspicion, but they do not diagnose. And the differential diagnosis tells us what it is not. So it excludes masqueraders that fully explain the findings. So how do we shift from is this dry eye to why is this dry eye, which is basically the crux of DUCE-3. Once dry eye is established, the key question changes. Why does this patient have symptoms? And this is where has been introduced the concept of etiological drivers, which explain how homeostasis is being lost. Definition confirms the disease. Drivers determine the therapy. It was a privilege and pleasure to be part of the subcommittee of the Diagnostic Methodology group. And this was when we met in Venice, when the TFOS report was almost being finalized. The diagnostic methodology, which basically introduced the concept of etiological drivers in dry eye disease. So what I've done here is kind of just broken it down into the 4 main drivers, which are considered as etiological drivers for dry eye disease: tear film deficiency, eyelid anomalies, ocular surface abnormalities, and systemic drivers. Each of them are further subdivided into aspects which constitute them. Subsequent to that are the standard testing modalities for each of these etiological drivers, which will help us understand whether these drivers exist in our patient or not. And finally, the advanced testing, which helps us confirm whether these etiological drivers are present or not, or they help us establish to some extent as to whether these drivers exist or not. So to put it in a diagrammatic format, the etiological drivers are the tear film related deficiency in relation to the lipid layer, the aqueous phase, and the mucin. These are the ocular surface abnormalities, and these are the eyelid anomalies, with the 4th driver being systemic associations for dry eye disease. So this is what was done in DUCE-3, that we moved from labels to mechanisms. The diagnostic subtyping, which is aimed at identifying what is the cause for the symptoms and signs that the patient has. And in addition, most importantly, an explicit recognition of the fact that you can have multiple concurrent drivers in the same patient, which all needs to be identified and addressed. Subtyping exists to explain symptoms and not just name the disease. So this is where the next layer comes in to DUCE-3, where once you have diagnosed a patient to have dry eye disease, you try and identify the etiological drivers, which are divided into 4 main subheadings: tear film deficiencies, eyelid anomalies, ocular surface abnormalities, and associated systemic problems. And then you divide each one of them into subcategories. You tick the problem that the patient has. So that helps you in management and therapy as far as treatment of your patient is concerned. So what exactly are etiological drivers? It enables targeted, individualized treatment planning. It links clinical findings to appropriate therapies. It moves beyond broad categories of aqueous versus evaporative. It addresses multiple simultaneous drivers, and ultimately, it helps us improve patient outcomes and quality of life. So how then do we identify these etiological drivers in dry eye disease? Driver-specific investigations for tear film include primarily slit lamp evaluation, interferometry, the lipid layer thickness, the mebum analysis, breakup time, and mebography for the lipid layer, the tear meniscus height, Schirmer's without anesthesia, and the DATs for the aqueous phase, the rose bengal or the lysamine staining or the fluorescein staining with the yellow barrier filter for understanding the conjunctival staining, which helps us assess the mucin layer of the tear film. For the ocular surface, one needs to look at anatomical disturbances using the slit lamp, neural dysfunction, which is evaluated by corneal sensation, primary inflammation that manifests in the form of hyperemia, and ocular surface damage, which manifests in the form of staining of the cornea, the conjunctiva, and the lid margin. In the eyelid, we are specifically concerned about blink, which has been included as an important assessment that one needs to do in patients with respect to the rate, the completeness, and the seal, the adequate or the inadequate seal, and the lid margin with respect to presence of blepharitis, meibomian gland dysfunction, lid margin keratinization, and any other specific eyelid related issues. So what I must do versus what I may do for these patients to identify the etiological drivers. What is essential is symptom assessment, tear film stability, the NIBUT or the fluorescein breakup time, ocular surface staining, lid margin examination, blink assessment, and slit lamp evaluation of the ocular surface. These are non-negotiable. The tests that I may do are tear osmolarity, the Schirmer's, the tear meniscus height, the mebography, inflammatory biomarkers, and device-based tear assessment. There are certain specific cutoff values and criteria that have also been provided by DUCE 3 for each of the parameters that are highlighted here. So when you look at DUCE 2, we are all aware of this picture that we have been using in several presentations over the past few years, where we have always tried to categorize dry eye disease into aqueous deficient, evaporative, and of course the mixed variant of dry eye disease, and then manage to restore homeostasis. And this was how the patient came into the label or diagnosis of dry eye disease, which maybe is largely similar to what DUCE 3 also does in terms of triage. And this is the classic triage that we used to do for DUCE 2, where once the dry eye diagnosis was made, all that needed to be done was put them into either of the two boxes or a mixed box and then have management. When you look at DUCE 3, it's a little different here. What we do is a screening questionnaire and the markers followed by identification of the etiological drivers. So between the two of them, same signs but different logic. Here it was symptoms plus any one abnormal sign, whereas here it is symptoms plus evidence of homeostasis failure. The signs have been grouped by biological meaning, and it requires interpretation of what has failed, especially which domain of homeostasis has failed. So DUCE 3 did not really change the tests, it changed how we interpret them. And how triage differs in DUCE 2 versus DUCE 3 is that in DUCE 3, triage is used to interpret the disease. In DUCE 2, triage was always used before the diagnosis, and the purpose was to decide whether this is dry eye or not. Whereas in DUCE 3, the purpose of triage is to decide why this dry eye behaves the way it does, and it excludes masqueraders and explains the symptom sign mismatch. Diagnosis is a checkpoint and is not the end of thinking, and it leads to etiological drivers. So DUCE-3 basically follows an interpretive mechanism focused flow, unlike DUCE-2, which we probably can call as a linear flow now retrospectively. So DUCE-2 used triage as a doorway, whereas DUCE-3 uses triage as a compass in dry eye disease. So when you look back at the slide that we began with the application of DUCE-3, we would probably say that the first patient has dry eye disease with tear film instability due to meibomian gland dysfunction, partial blink, and digital screen use. The second patient would probably be described as dry eye disease with tear film instability, ocular surface failure due to aqueous deficient dry eye, post-inflammatory ocular surface misalignment, though the last two would still continue to remain in the same box that they did as far as DUCE-3 is concerned. So this is how the final algorithmic flow of the approach to a patient of dry eye disease is with DUCE-3. And for each of these three etiological drivers, the DUCE-3 basically with presence of any of these drivers plus the risk factors is what helps us decide how we would manage these patients, which brings us to the next report in DUCE-3, which is on management and therapy, where the philosophy is to treat the source and restore homeostasis, which is driver-based mechanism-matched therapy, where you identify the cause and target the therapy. Evidence-based algorithms have been linked to etiological subtypes. The goal is not escalation. It's not a step ladder approach. It's a restoration of tear film and ocular surface homeostasis. And though it looks like there are 4 different steps, basically it's a staged management. You can pick and choose what best suits your patient. And it gives you these kind of figures where for each of the etiological drivers, it summarizes what the driver tests are, what the treatment modality should be, and amongst the treatment modality, it further subcategorizes the treatment into ones which are evidence-backed, ones which are adjunct therapy, and ones which are still exploratory, as I shall put it together. So DUCE-3 divides management categories into 10 broad management headings based on lifestyle and environmental modification, tear supplementation, treatment of eyelid abnormalities, anti-inflammatory pharmacological therapies, oral antimicrobial agents, ocular surface promoters and regenerative therapies, treatment of anatomical ocular surface abnormalities, nutritional modification and alternative therapies, prevention and treatment of iatrogenic dry eye disease, and surgical management of dry eye disease. These are categories. These are not a severity ladder. They're not meant to be used sequentially. It deliberately avoids ranking them as early versus late, and selection is driver-based combinations. So what I have done here is for each of these, here we've clubbed 2 of them in each slide, where we have tried to categorize the therapies into core therapies, adjunct therapies, and exploratory or outside the framework of DUCE-3. So most of the therapies that we already follow have been subcategorized as is shown here: preservative-free, artificial tears, lipid-based lubricants, punctal plugs, screen hygiene. Lifestyle and environment is something that is common across all dry eye diseases. Treatment of eyelid abnormalities and anti-inflammatory pharmacological therapies, which includes IPL, thermal pulsation, low-dose TTO wipes for Demodex-related disease as adjunct therapies. So you can see the entire list here, which has, for the convenience that I have categorized it into what are the core accepted therapies, the adjunct therapies, and the ones that are still experimental or exploratory. So this helps us pick up what we want based on what the etiological drivers are. And there are several of these which have been grouped together, some of them which have been recently FDA approved, and the ones that are still under experiment or under exploration. So these are just, again, putting your therapies categorizing them based on whether they are evidence-based and what is the mechanism that drives these therapies within what we call as the DUCE-3 algorithms. So we spoke about risk factors in DUCE-3 diagnostic methodology. Where do risk factors sit in the DUCE-3 management? So they do have a role to play even in prognosis and prevention, where presence of risk factors help us guide counseling, follow-up, and preventive strategies. They influence long-term management planning for these patients. So if I were to summarize DUCE-3 and what I have said so far, if you look at the structural evolution of DUCE-3 versus DUCE-2, DUCE-3 consolidated the entire report into 3 core documents, where concepts were merged into clinically coherent framework with a strong emphasis on clinical usability and design for real-world adoption. So it moves from an encyclopedic reference to a clinician-facing framework. These were the individual reports that were part of DUCE-2, which was exhaustive, but it had to set the base or the foundation for the academic granularity that DUCE-2 provided us with. The DUCE-3 digest is the third part of DUCE-3, which basically puts together the various key areas of dry eye disease and summarizes the interdisciplinary research across these areas. And these are some of the key takeaways of the DUCE-3, where I've just summarized all the key differences of DUCE-3 vis-a-vis DUCE-2 or the earlier versions. So what exactly does DUCE-3 mean for my clinic tomorrow morning? I will start with symptoms, not signs. I will ask why this patient is symptomatic and not just label the dry eye subtype. I will screen efficiently using the OSDI-6 and avoid questionnaire overload, and I will limit diagnostic tests and interpret them thoughtfully. So and then I will actively look for what is driving the dry eye disease in my patient, and I will match treatment to the dominant driver. So my goal will be to restore tear film and ocular homeostasis as far as treatment is concerned, and it helps me move from protocol-driven care to patient-driven decisions. How much do I depend on meibography if I were to just ask a question? So meibography, as per DUCE-3, is a context-setting tool. It's not a diagnostic gatekeeper. It helps me understand structural reserve. It does not, gland loss does not equal symptom burden. I do not treat the image, I treat the patient's dominant driver, but I use it practically to explain prognosis, to guide expectations, and to support but not replace clinical examination. So if I had to choose one test amongst all that I have in the OPD, well, I think it would be fluorescein staining, because it helps me to understand both the tear film homeostasis as well as the ocular surface homeostasis in the form of the breakup time as well as the staining of the ocular surface. And so this would probably be one test that I would choose in the clinic, and it also helps me differentiate it from the masqueraders or the differential diagnosis. As far as what T4's DUCE-3 is and is not, I think DUCE-3 establishes the current expert consensus. It defines how clinicians should think and act, and it promotes and provides a common clinical baseline. It guides practice. It does not critique history. It does not repeatedly compare itself to DUCE-2, and it reframes existing concepts, changing emphasis and priorities. So it definitely assumes that we are familiar with DUCE-2, and explicit version comparison is left to educators and reviewers. But where DUCE-3 meets tertiary reality, especially when we're dealing with very severe cases of dry eye disease, symptoms, yes, they define disease activity. Biology defines disease existence. So sometimes, as in the case that I showed earlier, severe aqueous deficiency may be asymptomatic, especially in Sjogren's and long-standing disease. So this is where we need to understand that DUCE-3 is a consensus foundation, and tertiary care exposes further frontier questions that are yet to be answered. Where DUCE-3 establishes a consensus, but tertiary practice reveals the unanswered questions that will shape further niche additions in this particular area. So neurosensory dysfunction is acknowledged but not yet operationalized. Driver stacking is recognized. That is, we recognize that different drivers can coexist in the same patient, but it is not prioritized practically. Treatment sequencing rules are not defined. Outcome measures remain sign heavy, and real world phenotype libraries. I mean, this is what happens when you're dealing with tertiary eye care, where you can have various things presenting together. So that becomes difficult. But of course, one needs to understand that DUSE-3 is the consensus foundation. It organizes clinical thinking. It asks why symptoms and which drivers first, and it is mechanism-based prioritization. It is shorter, not because it is simpler. It is shorter because it is more integrated. And this is just a slide that summarizes DUSE-1 versus 2 versus 3, where it clearly states how DUSE-3 has evolved primarily because of all the information that we have collated and collected over these last couple of decades, publishing the DUSE-1 in 2007 and the DUSE-3 in 2025. So with that, I come to the end of this talk, and would like to acknowledge my colleague, Dr. Bhaskar Srinivasan, who's also a panelist here, from Code Eye Care, Institute of Excellence for Cornea, Ocular Surface and Dry Eye in Chennai. I would also like to share details of the Catalyst Decode OSD, a group that is very active with respect to discussions, developing collaborative online dialogue and education in ocular surface disorders. That is what it stands for. Thank you.
Thank you, Dr. Geeta. I don't know, wordless. Wonderful, wonderful talk as usual. I mean, especially thank you for, kind of breaking it down to very simple terms, and, it definitely makes things a lot easier. When you go through the, detailed report, there are a lot of unanswered questions or, problems that come into your mind. But going through this lecture, I think a lot of things clear up a lot. Thank you once again for that wonderful lecture. Now, open for discussion. Any questions, comments from panelists? Himanshu, Dr. Himanshu, do you have?
Wonderful lecture. I don't think anybody can have any question after this thing. Geeta is as eloquent as she is always, and very nice, very nice. And Geeta, one thing I want to ask that DUSE-3 stresses upon diagnostic things like non-invasivity of breakup time and osmolarity. So does it mean that we are staggering diagnostic of dry eye into two parts, where some super specialists can have everything and some people cannot have these things? So does it mean they are not doing enough, or how do we take it? Like, if I don't have non-invasivity of breakup time, does it mean I'm missing out on something?
Absolutely not. In fact, that was the reason why, in fact, what DUSE-3 does is it narrows the bridge between those who have and those who do not have these diagnostic gadgets. Because if you look at the earlier version where osmolarity was literally considered as mandatory, here it has been clubbed with the breakup time. It is not 1 or 2 or 3. So you don't have a maximum of 3. You only have breakup time or osmolarity, which signals tear film homeostasis damage. And osmolarity, for that matter, or any gadget for that matter, if you don't have non-invasive breakup time, it clearly states that fluorescein breakup time is a very, very valid alternative to that. And therefore, what DUSE-3 has done is, in fact, it's moved away from gadgets a little bit. It's taken a step back. It is emphasized more on clinical screening, and it says that your diagnostic equipment is more from the point of view of enhancing. It has an additive role, and it is probably more to also do with research-driven investigations, but it's not mandatory for dry eye diagnosis. No.
So it's so true, right? I mean, we separated ourselves from categorizing dry eye severity and putting everybody through the same umbrella. Here, because of the etiological driver, we are seeking etiological driver, and which etiological driver is there. It's up to us, up to clinician, to decide which is the test which is most adequate and most accurate in their setup to look for that etiological driver. And possibly it also allows them to look for a possible future enhancement in their setup based on how such kind of etiological drivers are common in their practice, and maybe they can upgrade themselves to another level of more sensitive and specific test, which can always be looked up to. So that's so amazing that we don't need to be bound by the test, but we rather go and search for etiological driver, and whichever test appropriate for that etiological driver. Yeah, thank you. So nice. Thank you.
Yes, Himanshu, I think that's a point that you have always iterated, and everybody on this panel has always iterated, though we have always been appreciative of the added information that we get from these gadgets and the equipments. I think ultimately it's the clinical acumen and the clinical judgment and the clinical evaluation that scores a point over any of these.
Geeta, one basic question not related to this thing. How was the experience being part of this thing? So how was the process? Were you analyzing a lot of articles, or like how was it? If you can give some, if it's okay with you to speak about that.
So I think under the leadership of David Sullivan, I should say anything is possible. I mean, he's a tough taskmaster. So whether it's been the Deuce 2, whether it's been the lifestyle workshop that I was a part of, or whether it's been the Deuce 3 now, the subcommittees are very, very methodical with respect to timelines, deadlines, the amount of references that are looked into, which run into thousands. And then we have these kind of deliberations back and forth, even with respect to, what is a risk factor, what is an association, what is disease, what is syndrome, why symptoms, why not symptoms, why OSDI 6, why the earlier versions are not compatible across. That's why I said geographical boundaries, because sometimes, whether you have symptoms when you're working on the monitor might not really be relevant to a farmer in the rural areas in certain countries. So we wanted to kind of see if we could standardize things, but it was wonderful, because it ultimately it was like a family at the end.
It's so nice.
Yes, Bhaskar.
Bhaskar, you're muted.
Yeah.
When you're looking at the diagnostic methodology, I mean, you have the Asia Dry Eye Society, which speaks a lot on clinical diagnosis and talks a lot of in terms of breakups. Though the shift has been from gadgets to clinical, that in terms of looking at breakups have not been a part of the Deuce 3. So were there deliberations on that, and what was the so because of lack of consensus it was omitted? What was it?
You will actually see that it is a part of Deuce 3, the T-Ford, the breakup patterns. It is specifically mentioned, but also, like you rightly mentioned at the end, it's because of the lack of um, enough data consensus on how it should be done and how it should be brought into mainstream clinical evaluation is the reason why it's still not in. But there were deliberations about the breakup patterns. In fact, a short breakup time of less than 5 seconds with fluorescein has been taken from them.
And if I could just add a comment in terms of the discussion on investigational tools and clinical. Ultimately, even if you're looking at an investigational tool at this point of time, the person reading the maps or the person reading the report has to have an understanding what he or she is reading. You will have a patient with chalasis where your optometrist who does the test will then label it as TMH, which is very high. But then when you see the patient with fluorescein stain, you realize that it's actually the folds of the conjunctiva which actually misinterpret it. So again, even in most of the reports, what is given as breakup in terms of the report is normal the average breakup. When you talk of breakup, we talk of the first breakup. So you will have to go back to the machine to check, because it will give both the values. It will give you your first breakup, it will give you your average breakup. But when it gives you your report, sometimes it gives you the average because that has been set as a default in your machine. Third, even though we like to segregate things as aqueous deficient or lipid deficient and mucin deficient, somewhere all three coexist. A deficiency of one does affect the other. So when you're looking at it is good for us to kind of identify which is probably the more important parameter, but somewhere all three tend to have some association, where a decrease in one is associated with a transient compensatory increase in the other, and then everything kind of starts going down the line once it crosses a threshold.
Absolutely. I think very, very valid points. Yeah.
Bhaskar, that's the beauty of Dues 3, that going away from putting them into cage of aqueous deficient, evaporative mix. When you look at the etiological factors and when you are looking at the root cause, treating the root cause would be the right way to. And we have been telling each other, right, that treating the root cause is the most important. You cannot have a dry eye same where it's just just a computer vision and somebody with rheumatoid arthritis, just because their TBUT and Shermer values were same and staining pattern was same. They cannot be same etiologically. So if we are able to run after the etiology, or rather search for etiology, it would be so nice that we don't confuse ourselves whether which component evaporative part is more or which part, because we are looking at the etiology. Whether that particular etiology leads to evaporative dry eye, it's fine. Whether two of them together leads to evaporative dry eye, it's fine. But if you're treating that part, well, that solves the problem. So that's really the best part of this particular approach of etiological drivers.
Yeah, and I don't think any report can actually satisfy all ends of the spectrum of dry eye disease, because it is such a vast spectrum.
So here, Geeta, I think we should tell our viewers about the importance of fluorescent staining, which they recognize, and especially the method of fluorescent staining, especially avoiding the excess stain and those kind of things. So if we have to have only one test in our clinic, well, there has to be fluorescent staining. So such a simple test, all we need to possibly do is make sure that we do it in the right way. And if that's achieved, I think that's a very big step in our diagnostic for general ophthalmologists.
Absolutely. I think I should have added a video. Actually, I have a very nice video of how to do fluorescein staining. Right from, all of us stain with the fluorescein strip, because that is what we all have here in our clinics. And there's always this question of what do you wet the fluorescein strip with? So we know that the various media can actually alter the staining that you might see. The timing of staining, whether you do it before dilatation, whether you do it before the applanation tension is documented. So there are so many factors. So in general, if you could do it absolutely before anything has been done in the eye, that would be the best time to actually do a fluorescein staining, and use normal saline to wet the strip so that it doesn't alter the staining severity or the grading. You first look at the tear. It gives you both the markers. It tells you the tear breakup time, and it gives you the grade of corneal staining. And if you have a yellow barrier filter, it also helps you identify the conjunctival staining and the lid margin staining. So with just one test, you're done with your dry eye diagnosis.
True. I mean, from your incomplete blinks, your watershed lines and from your nocturnal leg ophthalmos to such a beautiful thing which we can interpret from one small little test, and making sure that we remove the excess drop on our tissue paper and put a very tiny amount of fluorescent on the surface would be very important. And I guess in future we should do those things of teaching them the accurate method of doing the basic diagnostic test. Thank you, Geeta. It was really wonderful.
I mean, actually, fluorescein, you should thank the Asia Cornea Society, the Asia Dry Eye Task, because once they published their work on the T4 and our interest in actually looking at fluorescein, not just looking, because earlier we used to just look at, okay, what is the breakup and whether there's corneal staining. All the other things actually started coming up after they put up their patterns of break. Then we started looking at tear film to look what all we see. Then we started realizing, okay, there are parts which are breaking up first regularly. So if you have an EBMD or epithelial basement membrane dystrophy or anything which is abnormal in the surface, you'll always get a breakup first in that part. So that doesn't classify it as dry, it probably classifies it as OSD, because when you look at tear abnormality, it's defined as a first random spot. If it's the same spot which gets shown up every time, there's an epithelial irregularity there which you need to focus on. You look at the flow from the lacrimal gland, that tells you whether the lacrimal gland is functioning. The tear meniscus height, you can easily see. Once you start seeing normal patients and then you put it, you realize this is normal, this is abnormal. Add on to that with the Shermer strip that every ophthalmologist has. Even if you don't have the gadgets, with the fluorescein and with the Shermers and with a little bit of common sense, you will be able to get your etiological drivers towards patient discomfort and treat them in a much more holistic manner.
In fact, if you see the DUSE 3 and the etiological drivers, this is exactly how it has been categorized. And very clearly, if you have an early tear breakup time or if you have staining, the first question that you have to ask yourself is this related to tear film or ocular surface homeostasis failure, or is it a primary epithelial disease, like you said, EBMD, or if it's a viral, even a dendrite can cause staining.
Even what you said, like dilatation drop or anything which has been intraocular pressure is checked or whatever. So it's so right that we try to correlate that finding rather than just taking it simply in terms of how many dots are there on the surface, cornea staining or not. So that's so right.
Yes. So in short, DUSE 3 has kind of moved away from gadgets to more of, clinical interpretation, judgment, and probably in addition, you just need one tear strip in most of the cases to get the answer.
Absolutely. I think a careful history taking, a keen observation when you are speaking with the patient to pick up blink related or blepharospasms or hemifacial spasms, these overall, when the patient speaks to you, when you're chatting, all that is then streamlined and it helps you come to a diagnosis. So I guess it's a comprehensive evaluation.
Correct. So thank you, Dr. Geeta. If there are no more comments, opinion, I think we'll conclude the session now. Thank you once again.
It's been a pleasure, and I would like to thank the AIOSSC Scientific Committee again. Thank you so much.
Thank you.
Thank you.
Bye. Thank you.
Bye.
Host can close the meeting.